Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist, and I'm here to help you find your airway answers. We're in this together. Let's do this. This is part 4 of a 5-part series, so please make sure you've watched parts 1 through 3 before watching this. And again, please show Dr. Grummons some love by giving this a thumbs up, and please also subscribe to my channel on YouTube, so go ahead and click subscribe to help increase viewers and keep this show going. Thank you so much. I appreciate it. Welcome back, everyone, to Airway Answers. You're going to go over more about Class 3 malocclusion, protraction face mask, and more. Thank you so very much.
Thank you very much again, Nicole. Okay, now we're to the part of getting a little more specific about occlusal plane and midline and what we're going to do with placement of the front of the maxillary component. So in flight, we know tip yaw roll. So we know about up and down, we know about occlusal plane, side to side, and we know about midline. So tip yaw roll is basically flying the maxillae. So the maxillae at all those sutures, I can take and influence them with the expander by putting the arms high and low on the arms, and then by having traction off the face mask. So in this example, one arm is high and one arm is neutral. So the arm that's high, when the elastic is placed, that side's going to be drawing down, and we're going to change the occlusal plane as they wear it. So it's like we're flying, but we've got crosswind, so we're going to bank a little bit to keep on our trajectory. And so I can bend those arms up or down. They come from the lab neutral. We have them made just to line up with the canines, and then I can take them up or down. And on the analytics, so on the computer readout, this is from the FMBO, which is a diagnostic service, but you can see the asterisks that make your eye draw right away. But one of the asterisks that's there is the point A, the convexity. So you see right on top, convexity is minus 2.5. Clinical norm is plus. So if I'm minus 2 and I should be plus 4, that's 6 millimeters that the maxillary base has to come forward. That's my answer sheet. That's my flight plan. So it doesn't mean I get exactly 6, but that's my target. That's my landing. And so I know the problem, what I have to overcome. And if that changes by 6 millimeters or 4 in the upper, that now tells me where the lower has to be placed to fit when we get to the finish. Okay, so examples on the left, my buddy Joe Caruso at Loma Linda, our chairman and colleague for 50 years, doing this together. We want to look at that occlusal plane. The palatal plane is really important to us, whether we're going to go up or down with things we do in the midface. And so with class 2 and class 3 types, the palatal plane is characteristic. We're going to measure ANS to PNS. We're going to, on the lower screen, show a utility arch. So you can see it's hitched up to the 4 incisors. So I can be moving those incisors down as the face arm and face mask are bringing the whole complex forward. I can bring the teeth down even more, tipping the occlusal plane, but in addition, erupting the teeth to get them down so they show when the patient smiles. And then I want to trust and verify. I want to prove that I actually did that. So 6 months, a year into it, I'm going to take a progress image. I'm going to retrace that. And you'll notice the upper molars have moved forward that much and come down some. But look at the front teeth that come down several millimeters. And point A is up there having come forward 3 or 4. So the base has come forward some. The incisors have moved a lot. It really changed the placement in the face. So I want to see people when they present show these kind of things, not just a picture before and after and say it looks great, and it does, but where did the change happen? Prove it. And then publish that, because the more you publish it, the more the airway benefits and traction will get in the journals and be the message. So, okay. And then if we're going to bring both arches forward, that's typically a teen that I'm not going to be able to do orthopedics on the midface. I'm going to relocate the dentitions. So these tracings show that the upper was able to be moved forward by him wearing the face mask, but this is orthodontics. This is not orthopedics. It's class 3-ish, but I've changed the placement of the 2 arches and angulated them forward with a lot of benefits. This is an example showing if I look at the tracing on the top right, you see the point A didn't change. The maxilla came down, but it really didn't come forward. The upper teeth are down and the upper teeth are angled out, but I really didn't do orthopedic. Point A, the tracing is the same. Lower front teeth went from red to blue, came down, I intruded, brought them forward. Why did we intrude? Because if the lower intruded, the lower left screen, now the upper could come up and over, but also come down. So they show in the smile. Proof of that is in the top tracing. The lower front teeth went down and forward, upper teeth came down and forward. So they show. So I wanted to prove it. All right, let's take this young girl. Dad's an orthodontist in Monterey, so they flew in. And grandpa, excuse me, not dad. Grandpa flew the kid in because the kid had a lot of airway issues and they were not getting help. And so they flew in and a lot of nasal resistance problems, function flow problems, rhinometry. Rhinometry was being done there, which really helped. So we knew some things. And we also knew, and this orthodontist colleague there knew this research that was in the literature, that as we expand, we get not only more perimeter to the arch, but we get more nasal airway so that it helps flow, helps turbulence. And so if we imagine 10 millimeters of expansion, that's 24% change in flow characteristics, which are measurable and certainly make a difference in breathing and sleep and all functions. So ADA policy in effect in 17 says we need to be checking these kids, helping for these things. This grandpa knew that with his granddaughter and said, we're gonna get on a plane and go get help. And so just like you drove to get help for kids, we have a lot of people that commute in, and we'd love to see there be a network of all people up and down every street doing these things, but they aren't. And we all struggle with trying to help the message get out there, and I'll have some ideas later on here to talk. But this case was used and presented to that panel at the ADA in 2017 when all this was being led by Steve Carstensen and others to help us with that. So Raphael took the case in, Mark Cruz took it in to present it along with Steve. And so it's showing what the benefits on somebody young, expanding the upper, moving things forward, getting the teeth corrected, of course, but the airway changing, and we back it up with research. So this is Bassetti and McNamara, but they're making the point that there's forward displacement of the maxillary complex from the pterygoid region. And so the whole morphogenetic placement of the mandible is different, but the nasal maxillary complex has come forward, opening up the back region of the airway and making tongue space. So this is her. So the big blue arrow on the right is showing the maxillary orthopedic change, and the little arrow on the left shows the dental alveolar change, tipping the occlusal plane down, the teeth come down. On the right side, the teeth are down where the lips are. So when she smiles, it's pretty. And other research showing that if we use these protraction methods, we're definitely helping the airway, the upper airway, which is what this is all about. And she goes from here to here in about 8 months and restores breathing and sleep. And she's a alert, bright, active, thriving girl now. So it was a convincing type of case to present there, along with the many others that got presented. But here's the airway change. And again, I want the coronal view and I want the axial view. Then I can really see what's going on in the airway, but that's her. And life was good. And then when we do the analytics, it does cost money. So I early on purchased the Dolphin Airway. So we moved the data, the CBCT data, over to Dolphin and Anatomosh, and we use those to construct some of the other renderings and views. And I had the privilege of working with those guys from the beginning. So this was the crazy bunch at the beginning. Mark Lemchin from New York was a brainchild, and then Chester Wang and the rest of the team. But one of the first digigraphs was in our office in Marina del Rey. So we were there when those guys were coming in and finding our way. And then years have gone by. So we've been allied with them. And I highly believe in their products and utilize them. And in fact, those guys today have gone on with Zeno, which you're starting to hear about, but it's use of robotics and orthodontics. And it's the same guys. So it's Todd Blankenship and it's Chester and Mark Lemchin. So notice them at the next meeting, but they're using Zeno and it's fun. Okay, so now the 7-11-year-old, we don't get as much orthopedics. So it's more 30% orthopedic, 70% dental alveolar. still beneficial, but not the same as it would have been on a 3 to 6-year-old. But it is face forward, same principles where we have an expander and we're going slow. Face mask is being worn, takes a few months longer at that age, but we still get real beneficial change. And a helpful idea is on the expander to extend arms up around the two incisors, the centrals, and cross over the midline. So as the arms expand, it keeps the two center teeth more or less together. So you don't get the big raging diastema that then obligates there to be some braces or other things put on to help the front look good. And so mom's happy and everybody's okay. It's a simple way to just keep that as a minimal problem. So it's just a design feature. When we're done with that, we just cut the arm off and keep the expander in to continue the face mask. Another example, putting arms behind the incisors. We are using brackets here, but I want the arms to keep teasing the anteriors forward as we're widening. So I'm getting orthodontic change along with the orthopedic change that the mask is delivering to get her to a good place. And again, the same article referencing that we're getting, change, positive change in the upper airway. And then just the concept that it's better to optimize the kid's structure, function, behavior than to repair them later as adults. And yeah, we can do incredible things with double jaw surgeries, chins, hyoid, all the stuff we do. But right here, we can do a whole lot in a simpler way. And the kids respond so quick. So here's this girl and ends up beautiful. She's only probably 13 or so in that picture. It looks older, but she's just, a beautiful young lady that has been transformed by this first phase. The second phase is easy, whether it's brackets, aligners, whatever is chosen. Sometimes nothing because the problem is so marginal. But I'm just saying what we do early is the most important for sure. And sometimes, yes, there are 3 phases, maybe a phase in the 3 to 7 to do the initial things, another phase late 10, 11, just to get arch development enough to finish it. Sometimes there's a third phase of aligners when they have all the rest of the teeth in. We almost always do it in 2 phases. But sometimes more severe problems, there's the deciduous phase, the mixed dentition phase, then finishing with the full treatment. And then here's the measure. Let's go back and prove it. Let's verify and validate. But we can see the change in the face, the mandible. You can see the facial axis rotated open about 3 degrees. And here's the change. The maxilla came way down and teeth way down. Teeth came forward and lower arch came forward. And I intruded the lower front teeth so I could extrude the upper front teeth. And again, look at that smile. I mean, the smile is beneath the lip line. It looks very, very pretty. Okay, another example where I've done intrusion of lower and extrusion of the upper. Okay, then the research from others has to back it up. So theses have been done around the country by different departments because it's a interesting topic to residents. Studies done in Germany is one of these. A study at UMKC, Kansas City, another one at Loma Linda, another one Hegman in the Oral Facial Journal. But you can see the number at point A is relatively similar. 3.5 to 4 millimeters is the typical change we net out at point A. That's a lot. And it really changes the nasal respiratory complex by relocating that much. So that's validation. And if it's an older patient, we can still overcome things. But here's one that had 3 phases. So the early phase, it's all deciduous, had sweeps behind the deciduous teeth to tease forward, face mask, and she's gone from underbite to, scissor bite, but we're getting her up and over and then brackets to finish. She's a dental assistant today. So she was impressed by these things. But later I can't do as much. And again, the same research, except when they're older like she is, I can add some kind of TADs in the palate, use the same arms and do the same things, only to a lesser degree, because I don't have the orthopedic benefit as they get older. I can add TADs and springs to help cause the arch to come forward. So the face mask on the outside and TADs on the inside to help bring that arch up and overcome the problem. And when we have transverse NAP problems, and some vertical in this case, but I'm going to develop them first. I'm not going to do the classic thing of measuring how much crowding do I have. Oh, there's 8 or 10 millimeters. That's too much, so we're going to have to extract something. No, let's develop the orthopedics first and then reassess. And all of a sudden, voila, we've got skeletal development. And now we have room for teeth, and we can accomplish the rest of the changes and make it all fit properly. But when we've done the orthopedics, we also did what �𝐃𝐈𝐒𝐂𝐋𝐀 taught us. We've helped that airway increase, 10, 20, 30% because of the orthopedic change in the transverse. All right, what about the three-way? Sometimes this is misunderstood. Usually they're misunderstood. And so somebody might critique because they don't quite understand. When we're using this, it's not a retraction appliance. It's widening the arch, and the springs are relocating the molars. Molars in class 2s are always mesially rotated. You wouldn't want to say always, except Casco at Iowa published research on class 2 malocclusions, and 100% of the time, molars had mesial rotation on the upper. So they need to be derotated as part of our initial treatment steps. Well, what happens when we derotate? We gain space in the arch. So we gain arch perimeter, and we gain arch length within the arch. It didn't come back. It looks like we're distally moving the arch. We're relocating parts of the arch, and at the same time, the whole front of the arch comes forward. We could add a face mask to this if we wanted to ensure it's coming forward. But within the arch, we're getting width and we're getting length along the sides where we need it. And ultimately, we'll anchor these teeth to protect and preserve the space until we can move the other teeth into that space and bring the cuspids in without extracting something. So that's how the three-way works in principle, and it's not a retraction appliance. So I just want people to understand how it's used. And we can use it, and we can bring the arch forward as we did here with the face mask. But again, this is an example of the lower being intruded in the top center picture, and we're getting space because the arch is getting wider, and as it comes down and forward, there's more length, so it opens up space in the arch. But ultimately, the lower arch is lowered and the upper is brought down to display. Problem is, she's too old when she came in. I couldn't do it as well as I could have if I got to start when she was 8 or 10. So she came in, played us a pretty song the day she had her smile unwrapped. We call it unwrapping your smile, and we celebrate that. And she's a pretty gal, so we were able to do that for her. But the smile is below the lip line, and it looks very nice. What about intrusion then? We can intrude front teeth about 1 millimeter a month, 1 millimeter every 6 weeks, is quite a bit. If the force is light and it's segmental, the front teeth will go right down into that bone and then come forward. Adults, it takes about twice as long. We get 1 millimeter every 2 months of intrusion. The models on the top side are showing the same case with the front teeth tall and then the front teeth brought down to become level, and then the smile developed. Invisalign, we get about 1 millimeter every 3 to 4 months. It goes slower, but we can definitely intrude with the aligners as well. Okay, sometimes they just need a quad helix or something later on to hold that space that's been made after a three-way. So it's not retraction, excuse me. It's holding the molar placement while we can realign the rest of the teeth and then finish. Lower left is showing utility arch, holding those teeth down in place while the others are being brought into position. So utility arches are segments, and we place the upper and lower front where they belong in the smile. And we're considering at the end, that smile is going to be pretty for life. If it's too long, we'll make it shorter. If it's too short, we'll make it optimal. All right, so what about the malar process? Since we're relying on this region of the anatomy of the maxillae. So the malar region develops real early. So this is where Dallaire and Petit's x-rays and their knowledge and their publications in French, which we had translated back in the 80s. This matures real early. Around age 2 already, most of these sutures are already highly convoluted, and they're very supportive. So somebody with real strong malar processes like zygomatic arch, there's a lot of beauty. It's just pretty. A lot of people pay big money for implants, or we do implants sometimes when we do mid-face advancement to get that effect. But that's beauty. When we look closely, that malar and zygomatic region is a highly important strut in the face. I mean, there's impact, there's things that happen with life. So we've got to protect the orbit. And we think of it as this little malar that somehow if we put a face mask on it, it's going to change. But understand that it goes way to the internal lateral aspect of the orbit, and is highly supported by the zygomatic process of the maxillary bone, maxilla bone, and it's highly integrated with the other sutures of the zygoma, palatine, all this whole region, and then the frontal. So when we look at a different angle here, just look at how much anatomy is there and how much convolution there is of all these sutures. So it's highly supportive, but these sutures develop and mature a lot sooner than the other ones we think of that are circummaxillary. And there's undifferentiated mesenchymal cells, stem cells, that are, say, in the posterior attachment of the joint that repair and remodel. They're in all areas in these sutures. And up here in the zygoma, when we look closely at the anatomic studies, look at the suture line and how many switchbacks, just how convoluted this is. It's just a tortuous nature. And when we put load on, you can see that there's a initiation of sutural change. The cells are active and trying to do something, but that bone isn't going to suddenly displace. There's too much that's holding it. And so it can modify, but it's not going to change. And this is the proof of this is Dallaire and Petit's work, not mine. I learned it from them and trusted and built on their shoulders. But it's this is in my mind when I think about loading that region of the anatomy. So on a 2-year-old, I'm not going to do that. If I had to put a mask on a 2-year-old, I'd go to the chin, because I'd rather be on the chin and not risk anything changing here until it's mature. But 3 to 4, I have no hesitation based on what they taught me. So zygomaxillary sutures, they're resistive to remodeling, and they're highly interdigitating. They're longest and thickest of the maxillary sutures, so they're not going to change with the protraction forces. When we activate the other sutures, the zygomatic maxillary suture doesn't even show the same response histologically. And then the serial x-rays of Dallaire and Petit showed us these areas were stable, and point A changes and so on. And then after all this in mind, that gave me a basis to go ahead and design the one that we have. And so this is just emphasizing again, what's in my mind is the bony support that's around here and how reliable this is. And then looking at the sutural regions, the histologic regions, how reliable it is. So I think it's divinely designed to protect the eye, the orbit, all the structures, develops and matures early. The maxillary skeletal deficiency tends to have a flatter prominence. So that you would think, well, we can't put pressure on that because it's developing, except it's already developed as much as it's going to. And like the chin is flat, and so we have to augment it with implants sometimes. And if it's a real complex case, we might do a high Lefort too and modify this or do something at the time of surgery. So going ahead, class 3, older patient, we're going to have a VTO or a visual treatment objective. So we know the problem. What are we going to do? So that is basically in my mind. What's the problem? How much am I going to change it? What's my plate plan? And if I'm using bollard plates, then these are going to get put in. I'm going to use the benefit. This is up in the maxillary component. It's not in the zygoma, it's in the maxillary component. But I can use class 3 mechanics, like I said earlier, or I can use a face mask and bring the dentition up and over with slow expansion. So this would be orthopedics a little bit, but this kid's older. So it's basically rotating the mandible open. The arc is opening up. So he's less prominent in the chin. And I'm slowly bringing the upper arch forward to get up and over and correct it. One thing we don't do on those patients when they're class 3 mid-face deficiency and a little older, typically there'll be a speech problem. Obviously the tongue placement, all the articulation isn't able to be optimal. I had a case come in from Orange County where they realized the speech was a problem and they did a partial uvulectomy. Part of the uvula was actually trimmed off, thinking that was part of why he was snoring and having sleep problems and not understanding the effect of the mid-face deficiency. So yes, there's cases we see where a long uvula might be observed. We're not going to touch it. We're going to do other things. But this person had hypernasality, which wouldn't be a surprise because you rely on that part of the soft tissue to go up and close off to have normal speech. So that was the biggest disadvantage and consequence of having done that. So we make
And
sure,
probably the uvula being elongated was a consequence of the sleep disordered breathing,
yes,
not necessarily the primary cause,
thank
right?
you. I learn from you every time. Thank
Yeah,
you.
right,
Oh, you're
right.
right. Right. And so the more lower is expanded, the more I can expand the upper. So we've shared that concept. So we're back to Miner's work. The lower is going to get looked at on the coronal view, the frontal view. And even back when I was taking x-rays, doing all the original frontal work, I always flipped the x-rays to be an AP. So classically an x-ray is a PA, and we flip it so it's an AP. So we're looking at the patient. So anything we analyze and see, if it's short on one side, asymmetric, off center, we're seeing it on the patient, seeing it on the image, seeing it on the photograph, seeing it in the chair when we're observing. It's all consistent information. But Miner comes along and teaches us all these different angulations and convergences. And so we then say, well, the lower needs to be uprighting transversely. Even a simple Schwarz appliance initially can start tipping those teeth upright. And they don't just tip at the apex. There's a center of resistance and a center of rotation. So even something as simple as this is going to start uprighting the crown, but the root is actually going the other way. It's like when you take a pen or a pencil, if I hold it at the end and move it, it's just going to move outward. If there's a center of resistance, so when I hold that, it's going to actually rotate around that center. So the top might go out, but the root tip actually goes the other way slightly. So we don't overuse this, but it's evidence it starts to upright the arch and spaces open up. So we prescribe these regularly before aligner treatment. If the arch is a little crowded and tipped in, it's so simple for 8 to 12 weeks to use this to start decompensating, unlocking spaces. The aligners go in and the patient's comfortable. Plus the teeth have loosened up and started to move, and the aligners go in and there's space to work with. Well, same thing if we're doing expansion and change in the midface. The lower's got to have something to bring it to be optimal. It can be something simple. It can be a coil spring loaded device. This is great on mixed dentition kids, on deciduous kids. It's really easy to start uprighting the lower arch while the upper is being changed. If it's aligners, we're going to put attachments on the inside so the aligners have a positive engagement. So they upright that lower arch. So it's just having some different thinking. And rather than have the technician do it for us, we actually want to participate and guide that. The lower, we know it typically has to come forward. So I showed you on class 3, the lower might, and class 2 might require that. Well, we're going to put these torquing lines on all the anterior teeth. So I can change and control the angulation rather than just letting them tip according to what the technician decided. I want to control that. There's a reason, there's a plan I'm trying to do. Okay, I'm talking about a few patients here that are a little bit older. And so this guy comes in.
Hi, I'm Caleb. I got a bad underbite and yeah, and I don't sleep very well. I fall asleep in class a lot. And yeah.
And I'm Kathy, his mom, and he sleeps horribly. He tosses and turns a lot. He complains he's tired all the time.
Ready for it.
He has problems falling asleep. He has problems staying asleep, and it's cranky.
So Caleb, mom said you're cranky. What do you have to say about that?
It's true.
I just love that about the guy. Well, older kid, so we proposed face mask, all that. No way. Junior in high school, surgery. So these kids, 6% of the 10th grade, supposedly, small percent of the higher level kids are not getting enough sleep. They're studying hard, they're playing hard, the video hard. So a lot of things are going on. And so we need to really give a lot of attention to those kids. So here's a kid in the older age, a lot of sleep disorders from out of town. And he gets started with his dentist who's doing some orthodontics and sees the crowding, narrowness, and takes his records. And the treatment begins there, and they removed 4 teeth. Any of the rest of us will look at this, expand the upper, bring it all forward, everything I've talked about, both arches forward, and overcome it. And this is when he presents. So he comes in now in progress for a couple of years at least. And look at this lower arch and how's the tongue supposed to fit? and they can't close the space. Why? Because the tongue's in there, and the tongue can't stand any more compression and closure and retraction. So we look at this and say, I wish I could have had first chance. And the parents are, talking lawsuit, all that. We always try to settle that down, and we did. I said, let's focus on what we can do for your boy and get it done before he's out of high school. And so anyway, this is his models when he presents. So he's all the mid-face problems, class 3 underbite, but missing some teeth. So, this reminds me of what I often tell people when they're showing me cases. One doctor said he couldn't treat it non-extraction. The other one said he could, and they're both right. Because with what they know and do, one has that wherewithal and additional knowledge to apply all of this, and another one is still doing it the way we were trained instead of the way we've learned to do. And so the kid can't sleep. They grow up, they've got narrow arches, they got sleep problems that continue. And so I won't spend too much time on that, but this is his. So he's got a negative convexity. So this is where we get into the diagnostics. I've got to see something and measure it. And I've got to see where that jaw is, because I'm not going to orthopedically do anything for him really at this age. Convexity should be +2 to +4. His convexity is minus. So there's -4 to -6 millimeters of discrepancy of where that jaw should be. And they're trying to make the teeth fit with the jaws not matching. So we've got to think about the skeletal part. They don't want to do surgery. Do whatever you can, doc. We're not doing surgery. My son, that's what I would be planning. We'll do the most for him. We'll help his airway the most. So I trace them out, and then top left is where things are as we initiate. But I'm going to bring the upper arch forward and help the airway, of course, and let the mandible be neutral in its posture. So here's his airway at the presentation. Front teeth are crossbite. You can see the choke point, cross-sectional area, all those things that some people value a lot. We look at more from the frontal and axial. But there's this tracing, and growth to maturity is another feature of these computer programs. It takes the data, and using computer functions, we can grow the patient to maturity. I showed you in the first session, our son at age 5, his height prediction, his face prediction. So this does a height prediction within 1/4 of an inch. So it's pretty interesting and helps us understand the visual norms compared to what this kid's going to have. And this is his growth to maturity with nothing done based on the original images. So I did that to show it was really a class 3 mid-face that actually was deserving of a surgery problem correction. So then we do the analyses without boring you too much, but I'm showing you that we're going to try to get to the top right where his lips and face are reasonably balanced. And then I have to trust and verify what did I do and not do by following up afterward. So there's the forecast of maturity, and his teeth are pretty close to that at that stage. So I've got a lot to overcome. Typically, how would we overcome? We'd move the upper jaw forward. And these are examples. And this was back when I was doing a year, 15 months in Missouri. So the rest and I did a lot of cases together back in St. Louis. But we normally would bring the upper forward for sure. And then it would correct to what you see on the top right. That's the norm. So for him, I'm going to open the spaces for the 2 upper missing teeth, going to reopen it, relocate the arch forward. I gave him the face mask to help in relocating the lower dental arch forward, because remember, he'd had teeth taken out. So I needed the face mask to assist in bringing the lower forward. But guess what? We're not going to put back the 2 lower premolars that were taken out. We're going to bring things forward and make room for the 3rd molar. So you look on the lower and you see the 3rd molars are now being brought into the arch. So I've actually got a full complement of lower teeth. It's just that I'd like them more forward. But if I bring them forward more, I have to bring the upper forward more. And the upper's limited here because of the anatomy, the skeletal base. So the upper, I can open more space, but the lower, I'm going to resolve it by keeping 3rd molars, and that works. So here I am opening space. In a lot of cases, we open a 3rd premolar. So that's not a concept that's new. That was something we were doing in the 80s because so many people were commuting into the Marina Del Rey office that had teeth out. And we did other treatments, replaced those teeth, or did surgeries and or replaced teeth and did surgeries to get a good result. So for him, I had that background to say, I know I can bring the upper forward, relocate the lower helped the airway by bringing everything forward. So that's way improved. He still snores, but he snores lightly, according to mom. And I wanted a video, never got it. And he had a classmate, this girl from the town they're from, it's about 90 miles from here, who had community, and she had this beautiful smile. But I had brought her uppers down, and you can see her display. And we had her on the wall in the office because it was just one of those smiles that lit up. But he wanted her smile. And had no idea they knew each other. And he came in one day and said, I know you straighten her teeth. I want that smile. So I said, we can have something similar, opening the space and then bringing the upper teeth down in front. And here's the airway. Tongue is not up in the palate. You can see the tongue positioning, still mouth breathes, light snore and all that. So we haven't overcome that. But that's how I treated his case. So the top right shows where things ended up. Okay, so let's look a little more into cone beam then, because I'm relying on cone beam, Dolphin airway, Anatomage airway, and of course the in vivo airway. Those are the software I use. So I've published, this is in our PCSO bulletin. Ken Fisher, good friend and orthodontist, is the editor of this. The first time they started this column for the journal, Ken wanted me to do this on 3D, so we did on cone beam. It's also in Dental Town and some other of our journals, but I'm just saying, colleagues, you need to publish your stuff, get it out there, and it validates what you're doing, but then you learn as you do that. And in doing these, I wanted to communicate the low dosage, the skin entrance dosage that is occurring. So daily ambient is 8 microsieverts a day. So do the math, 7 days in a week, 56 microsieverts a week. 56, if the number sticks in your head, just say 50-ish. That's what you get in natural sun, a couple hours a day out and around. Airport body scan, cross-country flight. So airport, 5 to 10 microsieverts. If you go through that scan, 400 cross-country. Medical and so on are way up as far as numbers. So what we get with the scan is actually less than ambient in a week. So microsieverts, periapical, pan, ceph, full mouth. Look at the full mouth x-ray the dentist does that nobody hesitates with. Every couple of years, get another full mouth, or sometimes maybe it's 5, but certainly some regular x-rays. We can take and create ceph pan with 20, 30 microsieverts if it's a limited field of view, and of course broader field of view for craniofacial or other things we're looking at, airway, we're going to have more, but it's certainly not a risk factor. So it's not even something where we kind of sort of think there's too much. The technology is so good, and there's such a minor limited signal that's necessary for the software to recognize and pick up the attenuation and identify what are dark and light objects, and we can colorize it based on software. So you and Mike are doing a great job talking about these things to help people understand better. But I just want to emphasize, depending on the articles we're reading and depending on whether it was 10 years ago or 5 years ago or now, the technology just keeps getting better. So there's less microsieverts necessary to create the image. And we've become very talented at the field of view we're selecting, and then how we're rotating the data, and then the screen prints we do and how we view the data. So it's become really good. And my interest in imaging also goes back that in the 70s, when I took Ricketts courses, they had laminography and tomography. I was really curious about that because we had so much TMJ coming in. I needed images to help me know what was going on and how to treat. So we put tomography in our office in the 80s when everybody else would send them to labs to get images, and almost none of the labs had tomography because it was too expensive a unit and there was a lot to know to get good images. So we put it in the office. So I was copycat. Ricketts had it. I was treating a lot of complicated stuff. I needed it, wanted it too. So we had that background. And then Dolphin comes along, and I showed you that. So I was early adopter there that started giving us the software in imaging. And then, yeah, there's a cost. But to me, it was the cost benefit. And I just decided it was worth it. And I created workflows so that 2 or 3 people could take the images. So on the fly, if I needed something for commuters, I wasn't going to schedule them because they just flew in from Kansas or something. So we begin to understand with 3D about capture, attenuation, radiation safety, software. This stuff is way better with cone beam than we ever had. And we opened about 30 labs under the name Wilson Radiology Labs in the 80s. And John Wilson, Joe Caruso, Roy Vigo at UCLA, and Bob Danforth, who's a radiologist in Texas, was at USC. So we went together and opened these to help colleagues have labs that could do these images in their communities. And then more supplemental is that we are responsible for what's on that field of view. So you don't want to take a big field if you're just looking at the maxillary sinuses or you're looking at the upper airway. You have to chart it, make sure you chart. So when we do medical legal cases, the charting is everything. If you didn't chart it, it didn't happen. So you need to chart stuff and chart that you scrolled the volumes and that you recorded the findings and do that. And I usually do it with an assistant handy. So she's keying in as I'm seeing things. So it's efficient and fast. You want to create a RAD report. That's where you record, just like a radiologist would read imaging. You want to create your report. And we don't always know enough to create it. I've created a lot of reports, but I've sent a lot out to my maxillofacial colleague who knows more. And every time I get it back, I use it as a tutorial to go through and look at what are they seeing and let me find it so I can see it too. And then the patient pays the RAD report directly, so there's not a consequence to you. They appreciate it. There's a value added. And we regularly outsource. I don't get cavalier and say, oh, I've taken so many of these, I can read them myself. No, there's always something here and there that looks different. I'll send it out. And then, like I say, create the RAD report. So we sit there and we do that with an assistant. If you're doing telehealth, remote monitoring, you want to have consent to do that. So just know medical legally, that's where we're at with things. So get consent, and there's forms for that. And some other remarks is that the intake exams are too hurried. Guys are in a hurry, ladies are in a hurry to get the patient started. Factors are being missed, especially airway stuff. It's just not getting treated. TMD stuff, periodontal stuff, pathosis are being missed. When we come along and sweep up and try to defend our colleague, if the stuff isn't noticed and isn't charted, there's a problem. And so a lot of parafunction and so on. Images are not thoroughly reviewed and recorded. That's a big problem we're seeing. The RAD report's hardly created. It's not in the chart. Loma Linda, Joe Caruso led the way teaching that. There's over delegation and kind of cavalier regarding regards of patients. And the main thing is make yourself defensible so that when we step in, we can show how good you were doing or trying to do it, and the standard of care is provable. And that's the Hippocratic oath we took anyway, so do the right best thing. Let's continue on with the class 3 midface deficiency. And obviously with the compensations of the lower arch, the tongue is confined and all the function of the tongue, the placement and so on is affected unfavorably. So the tongue might be up and over the occlusal plane, scalloping, different things that give us clues. So when that upper is really narrow and deficient, the lower has consequences, and certainly the tongue placement and airway are at a big disadvantage. Here's an example of a non-grower. So we're gonna free up the maxillary component, basically surgically release. We're going to put TADs in the front and TADs in the back, run a face mask, and we're going to expand the upper. And in effect, it's a SARPI, expanding the upper as we bring it forward. And you can see lower right before and after, basically how much the upper is brought forward. And his teeth don't need much more display, but they've displayed some. We do facial moulage, which is a function on the software, but his bone housing is thin. Periodontal attachment is thin, his biotype almost requires grafting in several areas, but nice, handsome results. So let's take that same case and dial it back if we could have seen him or someone like him at age 5 or 8. So this guy was under care at Stanford in the 80s, and he was told you can't have anything until you're done growing. And at that time, I was working with Nelson Powell, who's one of the surgeons there, ENT, and doing facial procedures. And so he comes in and he's a full ride scholarship at UCLA as a soccer goalie. And he comes in and I told him we can do the surgery and all that and help his airway and all those things. But a lot of cross bites, midface deficiency, asymmetry, hypoplasia everywhere, compensations everywhere. And certainly, even in this case, the malar rim, you can see is very deficient, which is typical and which we would like to have addressed much earlier in his life. Well, there's another feature to a case like this. I said it was asymmetric in the maxillary base. So when we are expanding the upper first before we do the AP, width first, vertical second, AP third. So we're widening it, but notice I had the surgeon do the release, but not cut through the piriform area on one side. 10 days go by, we're expanding the upper, but one side is still attached. So the other side is pushing out because one side's more crossbite. So then in the office, the surgeon does a top left screen. You can see the little suture where they've gone through with a bone burr, cut it, release it, and we expand out to width, and then follow that up by the forward relocation of the jaw and surgery. Big, handsome guy. He's a model. He's got a contract pro soccer. All those things happened. But up underneath the malar rim at the zygoma, there's an implant we had placed just to give him that definition. It makes a big difference for patients. So when I'm looking at mid-face deficiencies, I'm always looking at the rim and imaging that on 3D to help make the point. All right, let's go over to craniofacial, where their mid-face and airway problems are typical. A missing lateral, a cleft lip and palate patient. So we're going to develop the mid-face, help with the breathing, snoring problems. And so we're going to do the same things, only this is a lot easier, really, because the parts, if we didn't get a chance to do a molding when the kid was months old and so on, then we're going to, at this point, jump in and do all the mid-facial things and develop forward and wider and overcome that so she can be restored and made normal. The problem is this patient missing a lot of teeth, but the deformity is much more than I can handle with face mask type things. So we're going to have models early on. We're going to use the different software I've mentioned and get some of these beautiful renderings, which are interesting. We're going to start with a face mask to develop forward some, so there's less to have to do with the surgery eventually. So face mask, but she's older. I'm using it for arch development, getting the width, getting room so I can have room for that lateral incisor to be replaced. And then we use 3D Compass, which is a Brazilian software for facial and for surgical planning. It's beautiful. And so we've got our cone beam, CBCT facial wrap over it. And then we're going to plan out where to put the skeletal parts and then how that changes the face. I do the manual tracing so I can trust what I've known from my experiences. So I have drawn it out. I've traced out what I have to do. I'm rotating the mandible open 4 degrees. I'm relocating the upper, but I'm copycatting that on the software. So we're going to move the AP upper 14 millimeters forward. It netted out 13. Anterior vertical is going to come down 6. Midline is going to swing 4 to the right. So this is the setup. And of course, in surgery, we can't just do that because there'd be a huge gap. And we can't leave a gap without grafting into it or putting some median in there. So we're not going to do that. We're going to do it with distraction. So we're going to free the segments and we're going to bring it forward. This is more than a face mask can do, but it's mid-face orthopedics. So it's distraction, osteogenesis, DO, and it's 8 to 12 weeks. We typically select around 8th grade, freshman year to do this. So it's done before they go into high school because the facial benefit is so good. And we want them to have that when they go off to high school and meet new friends and so on. So this is May, 8th grade. So the upper jaw is surgically freed, but not moved until we attach the cranial, just the hardware to produce this. So it's coming forward. The airway is going to open up immensely, but the whole nasal maxillary respiratory complex is going to get changed and help. This is the part in front. It gets dropped down. So we loosen it, drop it down a millimeter every 2 or 3 days, a millimeter lower. Remember, the top came down 4, and then the sides can move up. So we move a millimeter a day. So it goes pretty fast. But remember, this is immature bone. It's just a blood clot that's becoming soft tissue and then, differentiating to become mature tissue. But we're stretching all that. And there's trays put in over the teeth that we attach to. So the whole segment is controlled and brought forward. And then from the side and front, the airway is benefiting. Maxilla ended up netting out 13 forward, came down 6. I misspoke and said 4. It's actually 6 that came down. So that's better yet. And midline to the right 5. So I need the coronal view also to plan this to know how far am I going to swing the midline so it ends up on the facial midline, not just how the teeth fit, but I want it to be centered on the face. And looking from the lower is not typically exactly symmetric. So the lower might be asymmetric, which it always is if we look close enough. So we're going to center the upper on the face, not center the upper to the lower. Because after going through all this, you want that smile centered, you want the occlusal plane level, and you want the front teeth down. So when she smiles, it's pretty. So I want to let that be the priority. That'll make the lower fit to that. So the maxilla is a template for the mandible, even in a case like this. That's where she was. You see the initial appliance with the arms, the face mask arms up on the side. So we're improving it early. And then this is the proof we're copying nature in her fundamental majesty. So let's prove it. Did I really do it? So the top shows the change in the maxillary base and where the teeth were and where they went. Look at the molars, upper molars, how much they went down and forward. And then look at the chin. The mandible is right on the same plane. The mandible didn't rotate. We just held it there. And so it didn't open or close, but the lower changed. And look at the lower teeth, how much they have been moved forward in the face. So the upper and lower arches have come forward. And so we don't use the forehead for any kind of reference because foreheads are front and back to the 2/3 of the face. We always want to relate the middle face and lower third because they function and look together. So we're not trying to make anything match to the forehead because different parts of the world, the foreheads are different cranial shapes, different cranial vaults. But she balances beautifully on the aesthetic line, the subnasally vertical. And then in the mouth, as we're finishing up, I put a little pontic in, bonded in from behind so she can have an aesthetic smile as she enters high school. And then we get that out, get a flipper in place of it. My choice would have been to bond a couple of teeth. The dentist and her agreed on a flipper, and that's fine, less expense too. But that was the maintenance until the final restoration. So why do we do all this? We want to give each kid the best possibilities in life. And it begins with airway and health and tongue function and all that. And if it's been done, it's probably possible. And if it's known, it probably exists. So that's something I've been saying since the 80s, just from learning this. And then how do we deal with some of our colleagues who might push back on this or not even think it's relevant or important? The priority of a kid, I mean, none of what we are or do matters except in the life of those kids and where they'll be 50 and 100 years from now, the lifetime they can have because of something we're doing now. So I've had the privilege of speaking on a lot of these meetings, our AAO probably 15 times in 40 years. So I had a wonderful opportunity from our profession, our organizations, and published quite a bit. And the point is, doing this, I think we have to earn it. So it's just not okay, it's my turn. It's kind of, if we're out there leading the way on these things and taking some heat sometime to stand for what might be right or the better thing, that first it might not be truth, but then later people will come to accept it if it is truth and validate it. So the times I've been on programs, it's been very positive for me. But you're prepared for what the audience might bring, because not always are the questions friendly and fun. So you have to have yourself prepared and earn it. And I've been program chairman for our foundation for orthodontic research 20 years or so. So it's helped me learn what is looked for, but also what is important in the background of a presenter, or looking at publications, having served as one of the reviewers for a couple of different editors on our HAO and Cranio and stuff. It helps us really learn to look deeper at what's true and what is there and what isn't. I counted recently, it was 48 states I've made appearances in for conferences. So wonderful journey. And I think our colleagues know really well, they've been trained really well on a horrible study of what happens when you plug the airway. So why not take that knowledge and look at kids that have plugged airways? And we know about tonsil adenoid, and some still wait and see or rely on the ENT. We should lead the way because we know and ally ourselves with our speech people, our language, our swallow, our mouth-functional people, ally ourselves with the ENT or the others in pediatrics that understand and have a belief in this because they have a knowledge in it. And so many of these colleagues don't know what they don't know, but what they do know isn't enough. So they might think, oh, we'll just put a mask on them for a few years until they grow out of it. I talked earlier about the negative effect on the midface of a nasal mask, of a mouth mask. So we're not doing that. We want to get the air box working. If they snore, you got to do more. So if they're snoring, we perk up right away. We want to know about it. So we want to screen every patient as if they're a snoring patient or as if they're an airway patient. So every one we're screening and giving a good history. Every one we want mom to get us a video of the kid asleep. And we want to know the ones with upper airway respiratory distress. And we want to teach the colleagues that the snoring patient gets on this cascade that's not generally good. So breathing problems are a pathway to sleep disorders and more, all the other health and medical disorders. So I'm not stagnant about it. I want to be a moving stream. I want to be fresh water, a flow of information, pursuit of the new information, just like Nicole is. So I admire what you do, Nicole, with all the guests you have and all that you do to teach and contribute. And I've had some giants. I've had a chance to walk among giants. These guys were doing airway back then when it wasn't anything like we know today. But we're standing on their shoulders. That got us thinking different. And when you think outside the box, it makes you analyze different and be willing to risk it and do what's better. But too many times people are in their own little circle where they're thinking alike. And there's a quote that General Patton did that says, when everybody's thinking alike, nobody's doing much thinking. And I think that's a problem too, where people aggregate around those with similar thoughts and philosophies. We're teaching this at Loma Linda, have been the whole time. It's our chairman, past chairman now, Joe Caruso, Jim Hilgers, and a bunch of us have been on that faculty a long time. Colleagues, you got to go hear Jerry Simmons, go down to his conference. You just have to, for all the medical dental knowledge you'll gain in a short time. Sign up and be a member of the AAPMD. Go back and learn their stuff, review it. Nicole's spoken for them at times. I have, and others have, and Michael Gelb and Howie Hendon and those guys have started this thing, and it's fabulous what they do. You got to publish, you got to validate your message. You can't just say, in my opinion, it's this. No, you got to measure it and validate it and get outside the box. I've been publishing a while, and it's not easy. It takes a lot of time, but at least put something out there. And when you put it out there, put it in a refereed journal if you can. And I like when these things show up where it says high confidence on top of the articles. That means in these other foreign publications, when we're getting referenced, it's a reliable journal, and they're categorizing these articles as being high confidence. So there's a trust, and we have to earn that. There's a book coming out by Bill Harrell, our good colleague that's worked so hard on this stuff all his career. I've known Bill since the beginning. Highly respect him, and great contributors. And Nicole's one that's in this book. So she belongs there. The message needs to be there. But I don't want to be anecdotal. I don't want to be flying my kite and just see where the wind takes it. I need to have a flight plan. I need to have knowledge, and I need to have it be reliable. I need to check myself and be willing to change. And I got to be careful who I listen to also, because smart is when you believe only half of what you hear or see, but brilliance is when you know which half. So I want to know that too. I'm going to keep carrying my message of airway and facial orthopedics with my colleagues. I'm going to reach the public, which we've done locally, both in the marina and up here, by having in service at the hospital, using community centers, public awareness forums, and Wake Network. We speak often and get invited, publish in your local magazines what you're doing. So I've done that many times. There's others that you might align with, maybe an ENT and a dentist doing sleep dentistry, a pediatrics person, a speech person, PT. So we often team up with 2 or 3 of us so we can be a team and then share information. And they don't always drink. You can lead them to water. They don't always drink, but give them some resources, some go-tos, so they start pursuing it themselves, and then they come to discover. And we speak, supporting them with articles and other things. Just we will do after these visits together. I'm going to give Nicole anything that would be helpful, but we don't speak with forked tongue. We speak with validation and truth. And I appreciate how much speech and swallow and myofunctional has to do with every success I have on a case. And then I've created little handouts that are, the schools have them, the school nurses have them, but it's a fact sheet about school screening for sleep problems in youth. And I've done this and revised it many times over the past 20 years, but it's simply the problems in a classroom of sleepy kids, breathing problems, things that parents should know about, but it's a 2-page online document, and it's also printed, and the schools hand it out. And you can be sure that in your community, if you're doing this, and a mom asks, who do we go to get some help? Because they've gone to 4 doctors and nobody's got an answer, they're going to end up coming your way, and then you can collaborate. So I also invite colleagues to come anytime and visit the office. I encourage you to do an in-office seminar Like Nicole encouraged to have some kind of 1 or 2 or 3 day on-site, hands-on type of training. I did it for 20 years in the marina, where we had 10 doctors at a time come for 3 days or 6 days, and they learn a lot in that time. So jump on board and try to be the best colleague you can be. That's what Abraham Lincoln taught us. I hope with all the stuff we've talked about, that man's mind, once changed by these new ideas or different ideas, can never go back because it's changed. So we've got 8 grandkids, Trudy and I. So what we do in their lives is better than anything that's a reward or an award or anything in stone monuments. This is what we do to weave into their lives, pour into their lives. And just day to day, go out there and be happy. Drives people crazy. And Nicole, time for a toast. And I have to do something. We started with just a little fun. So wouldn't this be fun? I think this is you in the world. This is what you're doing. Oop. You're lighting it up.
That's funny. I thought you were going to grab a glass of wine. So
There it is.
let's get the champagne. Oh, that's funny. That's sweet.
Something I've learned from physical therapists, but putting together as a guy, I think we should do upright posture. We should walk briskly, eyes up, shoulders back, a confidence, arms in motion, feet pointed forward. That's the way I try to walk. And I observe others around me where they're not doing that. And that's how we want to just approach life, like that river that's a stream just flowing. And I think you're doing a wonderful job for all patients out there, all your colleagues, your experiences and knowledge, your conviction to the truth. You know what you're talking about, the passion for kids and colleagues. It's authentic. You have a heart for it. There's clarity. Everything is worthy. And I just like the thirst you have for what's new and pursuit of new knowledge. So every day I just admire you winning the day. So that's what we see. So you're rocking. And so keep thinking, colleagues, keep rising, dare to soar. I'll see you at the top.
You are too sweet, Dr. Grummons. Round of applause, major round of applause for you. Wow. Well, I appreciate that so much. And that last part, thank you so much. And that is not about me. It is about you and all these wonderful, amazing people I'm talking to who are spreading this knowledge. I feel like it used to be maybe I'd have questions and it's like, who do you ask? Who do you talk to? Look something up in the encyclopedia back in the day. And then it's like search online. But all these airway-minded practitioners like yourself are so open and available and willing to teach others. And that is such an amazing gift. It's such an amazing thing because your motivation and your passion in what you do and to help people and to help children just stretches beyond anything else. And you're just there to get the word out. You spending all this time with us, volunteering to teach us all of this information, hours of information. This was a course. Is just profound. You are a true legend, Dr. Grummons. Thank you so much. I've had questions for you in the past and you've mentored me. You've helped me so much. And all this information you just displayed over the last few hours has just been so detailed, so amazing, so educational. All the great quotes you put in, I love that. You're like an oral architect with showing how you change faces, smiles, and the airway. It's all the components. So I learned so much. I do have questions for you, but we'll re-meet again and we'll do a final of just questions and answers about different airway questions from you as an orthodontist and about the protraction face mask. I have specific questions. So we'll meet again for that. When you were saying all these wonderful quotes, it made me think, the quote, I'll believe it when I see it. You know how people say, oh, I'll believe it when I see it. Well,
right.
What about I'll see it when I believe it? And we have to get these other practitioners to believe what we're saying, and then they have no choice but to see it. So people need to be open-minded to listen, to believe these things, to be open enough to believe, and they're going to see. And that's where more change will continue to happen. So I think there's a lot of people who are just really closed-minded and don't want to believe this, don't want to hear it, so they're not going to see it. So I think all this education that you're providing is helping with that shift, because by teaching more, educating more, showing articles, showing cases, showing the research, you can't help but believe it and you can't not see it. And then we're changed forever. So Dr. Grummons, again, thank you so much for all that you've done for the field, all that you continue to do, all your teaching, all your knowledge, and your willingness to share it. Thank you so much. It does not go unrecognized, and it goes greatly appreciated. Thank you.
Oh, well, thanks. Yeah, my privilege. Thank you, Nicole, for the opportunity.
Of
Right.
course.
Bye.
Thanks again. Stay tuned for part 5. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.